Hello everyone, myself Dr. Shivam here, Assistant Professor, School of Physiotherapy, Avilasi University. Today I am here to talk about topic ataxia and role of physiotherapy in ataxia. Genetic disorders or So first of all, we will understand what is ataxia, what is the condition, what are the symptoms, signs and symptoms and causes of ataxia. So first of all, we will go towards the definition. Then it is a neurological sign characterized by lack of muscle coordination affecting gait, speech, eye movements and voluntary action. It means the patient will perform an abnormal gait and have some difficulties in speech, and there will be some involuntary eye movements. So you can characterize that the person can be a ataxic patient. So the key features are the person will be having non-specific clinical manifestation indicating dysfunction of nervous system components that coordinate movements. So the common causes are multiple sclerosis, head trauma, alcohol abuse, stroke, cerebral palsy, genetic disorders or tumors. Multiple sclerosis is a condition in which the in the nerve fibers, afferent and efferent fibers, will decrease the capability of transferring the signals through them. And head trauma, as you all know, that any traumatic injury to the head will lead to affect our cerebellum structures, which will lead to ataxia. Now we will go towards the causes of ataxia. So the causes are of different categories. First we will discuss about acquired causes. You can say that the person was okay, but due to some infection or vascular problem, demyelination, malignancy, he had attained or acquired the ataxic state. So the first is infection of posterior fossa abscess, cerebellitis, and in vascular you can go for hemorrhage conditions, infarction, death of any structure, cell death, TIA, transient ischemic attack. Demyelinating conditions are multiple sclerosis and sensory neuropathy, and malignancy will consist of tumors. Toxin and drugs will include INH drugs, lithium, cyclosporine, cytosine. Now we will go towards the different category of causes, which is hereditary causes. In this, it can be progressive ataxias, intermittent ataxias, metabolic disorders like hyperammonemia, aminoaciduria, lipid metabolism में you will see that A beta lipoproteinemia, which are known inherited ataxic causes. In this, first one is brain surgery. If the patient has undergone any kind of brain surgery which had resulted some of complication in his cerebral structures, which will lead to affecting the coordination of the patient. Now next is head injuries. If the patient had undergone of any head injury, trauma, which has affected the cerebral cortex or cerebellar region, then it may lead to ataxic condition. Next is infection, any bacterial or viral pathogen affecting CNS. Next is brain tumors, any overgrowth of the structures, growth disrupting normal cerebellar functions. Alcohol abuse, if the patient is or was chronic alcohol consuming patient, through which it will affect the neurological pathways. Next is multiple sclerosis, in which I had told you before that there will be demyelination of nerves which will disrupt the nerve signals. And we have another type of causes, which is defects in DNA repair. Now we are going to talk about signs and symptoms of ataxia. So in the initial phase of the ataxic patient, you can see the poor limb coordination. He will not be able to walk properly. There will be loss of coordination in his gait patterns. And next is dysarthria, which is speech difficulties. He will not be able to talk the sentences properly. Next is progressive symptoms. So in progressive symptoms, first one is swallowing difficulties leading to choking or coughing. Next is reduced facial expression. Next is involuntary tremors in body part. And next is nystagmus. Nystagmus is a condition when the patient will do involuntary rapid eye movements, rhythmic involuntary eye movements, and he was unable to control those movements. Next is cold feet due to reduced muscle activity. There will be decrease of blood flow, that's why cold feet. Next is balance and walking problems requiring wheelchair in severe cases. Next is vision and hearing impairments. And the last is depression and emotional changes because of inability of the patient to do some work properly. It will create. So the next is types of ataxia. We will study it thoroughly, the types of ataxia. So first type of ataxia is cerebellar ataxia. It develops from the lesions to the cerebellum and its afferent and efferent connections. And its characteristics are, it affects the sensory perception, coordination, motor control. It can be early onset from the age from 4 to 26 years and late onset from the age of 20 years. And it will, if it is late onset, then the symptoms will be milder. And if you want to see that it is a cerebellar ataxia, then the presentation of the patient will be ataxic gait, limb incoordination, tremors, dysarthria and nystagmus. Now the next type of ataxia is sensory ataxia. It results because of loss of proprioception. What is proprioception? It is a sense of the body joints, which tells us that where our bone joints are aligned, are they aligned accurately or not. You can say this is the sense of relative body part position. So its key features are unsteady stomping gait with heel striking ground. Next is postural instability worsens in poor lighting, loss of position awareness. Now next we are having vestibular ataxia. Vestibular ataxia is caused by affected vestibular system. You had learned about vestibulocochlear nerve. So there is vestibular region also, which is responsible for the sense of position. And if the vestibular system is affected, then in acute unilateral phase, the patient will have vertigo, nausea, vomiting. And in chronic bilateral phase, there can be unsteadiness also. And now we will go to the next type of ataxia, which is frontal ataxia. It is also known as gait apraxia from frontal lobe lesion. You had learned about the cerebral cortex, and in cerebral cortex there is frontal lobe also. And if there will be lesions in frontal lobe, then it will lead to gait apraxia or frontal ataxia. And the symptoms or the patient presentation will be tumors, abscesses, cerebrovascular accident, normal pressure, hydrocephalus. Now next type of ataxia is mixed ataxia. The symptoms of two or more types of ataxia will occur together. It can be vestibular ataxia and frontal ataxia. It can be cerebellar and sensory ataxia together. Then that will be called mixed ataxia. So we had studied about ataxia, its types, its causes, its sign and symptoms. Now how will we find that the patient is having ataxia? So we will have to go through a lots of diagnostic and investigation techniques in order to rule out that the patient is having ataxia. So the first diagnostic intervention will be hematology test, blood test. We will go through the CBC count, creatinine level, liver enzymes, electrophoresis, ESR elevated or not, CRP, TFT, vitamin B and cholesterol. Now second one diagnostic intervention is urine analysis. In this we will check for systematic abnormalities, Wilson disease or any other abnormalities. Next is imaging studies, in which we will check by using CT scan, MRI of brain to determine any kind of tumors, trauma in our brain cerebral cortex region. Next is genetic testing. We will detect the gene mutation causing hereditary ataxia, chromosomal studies on blood lymphocytes and cultured skin fibroblast. Next is clinical examination protocol. So the first one in clinical examination protocol is we will check for the higher centers, cognition, memory, the patient is having memory loss or the memory is good, orientation, speech, any problem in talking, in speech, and problem solving. Is he able to solve the problems? Second one is cranial nerve testing. We will go for the test of optic nerve, oculomotor nerve, in order to check the eye movements, abducent, trochlear and vestibulocochlear nerve for vestibular ataxia. Next, third one is sensory assessment. In sensory assessment, we will check for proprioception, vibrations, touch, pain, temperature. Is the patient is able to feel the vibrations, touch, pain and the temperature, and is he able to propriocept the alignment and the posture. Next one is motor assessment. Motor assessment will include tone of the muscle, reflex are present, deep tendon reflexes and superficial reflexes are they present, range of motion of the joint, and is the patient having any kind of tremors. Next, fifth is balance. We will check the balance by using some. Now we will focus on the balance, because if the patient will have balance, he will be able to walk properly and do his daily tasks properly. So balance assessment tools include two types of tests: static balance test, in which push and release test, pull test, single leg stance test, static posturography. As the names are suggesting, push and release test is by provoking a push so that the patient is able to maintain his balance or not. And single leg stance test is that patient will stand in single leg so that he is able to maintain his balance or not. And we have dynamic balance test also. First is clinical sensory integration test, functional reach test, Berg balance scale, 5 times sit to stand test, time up and go test, dynamic gait index, tandem walking and 4 square step test. Some of the tests are telling by their name that what we will be going to do in order to check the balance of the patient. We have some other tests also, which are computerized dynamic posturography, clinical sensory integration test. Now we will go towards the role of physiotherapy, and you can also say the physiotherapy management of ataxia. So physiotherapy management of ataxia, we will have some primary treatment goals in which we will have to enhance the balance of the patient. Second is postural stabilization. He will be able to stabilize his joints, trunk, and next is upper extremity functions. We will enhance the functions of upper extremity in order to increase the functionality of the patient. Next is functional independence. We want the patient to do his ADL's activities of daily life independently so that he will not get some depressive thoughts also, if he will be able to manage his all of the things by himself, and it will be helpful for him. He can function properly independently without the help of any other person. Now, first we will assess properly before treating the patient. So, some validated tools for evaluating ataxia severity level and treatment progress. The first one is International Cooperative Ataxia Rating Scale. It is a comprehensive evaluation of truncal and extremity ataxia, gait assessment, nystagmus observation, and speech analysis. Second one is Scale for Assessment and Rating of Ataxia, focused assessment of truncal and extremity ataxia, gait patterns, and dysarthria evaluation. Third one is Ataxia Functional Composite Scale. It is a performance-based measure. It measures gait speed, upper extremity coordination, and visual acuity testing. Next is 9-hole peg test. It is a standardized assessment of upper extremity ataxia through timed finger dexterity tasks. And the last is computer graphic tablet. It is a digital evaluation of upper extremity ataxia using advanced motion tracking technology sensors, so you can check that the person is able to work properly with his upper extremity, or is there any kind of ataxic problems. So the physiotherapy treatment approaches. It is a principle-based intervention. The treatment programs vary according to ataxia type and individual characteristics. Proprioceptive enhancement and visual aids benefit sensory ataxia patients. Cerebellar ataxia requires stabilization training, and vestibular ataxia demands habituation exercise to reduce vertigo alongside vestibulocochlear and vestibulospinal reflexes stimulation for balance and improvement. So before the treatment, the therapist should check the stability of the mind, and is the patient okay or having any kind of depressive symptoms. And if the patient is having any kind of depression symptoms, then the psychological support will be best and useful for the patient who are experiencing frustration and depression due to mobility and coordination challenges. Professional counseling from qualified psychotherapist provides essential emotional support alongside physical treatment. Now, next is proprioception enhancement techniques. So, for proprioception enhancement, we have some of the strategies to increase joint, muscle, and tendon awareness by reducing postural instability. So, the first is proprioceptive neuromuscular facilitation. It is the most effective technique used by physiotherapy, and it is mainly used by neurology physiotherapist. PNF techniques using diagonal patterns to enhance proprioceptive input through functional movement patterns. And in PNF we have rhythmic stabilization. It is a slow reversal technique and resistive exercises to develop joint stabilization and body awareness. We have surface variation training, gait exercises on different type of surfaces, hard surface, soft surface, inclined surface, with eyes open and closed to check or challenge the proprioception. Next we have vibration therapy on the muscle tendon or whole body to stimulate the mechanoreceptors and enhance the sensory input. Next we have plyometric exercises, in which we have balance board, ball and mini trampoline activities to develop the dynamic stability and reactive control of the patient. Next is suit therapy, in which we will provide the next is balance training protocol. It will include proximal muscle activation. It begins with PNF mat activities to establish trunk stabilization and core control by using some core exercises, core muscle exercises. Next is neurodevelopmental progression. We will train the patient through bridging position, forearms, crawling, kneeling, half kneeling and sitting positions. Next is static stabilization. It will be benefit for maintaining position using approximation and verbal clues, then strengthen through external perturbation. Next we have weight transfer training. So it will develop our functional extension for dynamic stabilization through controlled weight shifting. The patient should be able to transfer weight, sit static and work dynamically with coordination. Next we have standing balance. In this there will be weight transfer to front, back and sides. There will be tandem positions, single leg stance training for maximum challenges. And next, posturography device. It utilizes the visual feedback from the postural oscillation to optimize balance control strategies. Next, now we will go towards vestibular rehabilitation. So for vestibular rehabilitation, we will include a vestibular exercise program which will include repetitive, progressive, difficult eye, head and body movements to encourage the movement adaptation and sensory substitution to address dizziness accompanying balance and dysfunction. Next we have Cawthorne-Cookse exercises, which is systematic progression of head and eye movements to reduce vestibular symptoms and improve gaze stability through habituation. Hampered by incoordination. These are activities which are actively repeated PNF like contractions for extremity coordination. These are the most important exercises used by physiotherapists in order to treat neurological patients, especially who are hampered by incoordination. So next we are having coordination dynamics therapy. It is developed by Dr. Gisela Scalo. CDT improves coordination dynamic therapy improves neuronal network self-organization through extremely precise coordination of arm-leg movements on Geiger MD device, promoting functional CNS repair through coordinated neural firing. So after the physiotherapy management, we will also require some of the supportive device for the patient, and those adjunctive supportive device can be weight and walkers and extremity weights enabled improve function and current ability level when restorative treatment insufficient. So some more adjunctive supportive interventions are sports activities. We will enhance or encourage the patient to do some sports activities in order to develop the coordination skills. You can also go for horse riding, swimming, billiards, golf and darts provide enjoyable functional coordination training. Next supportive intervention will be nutrition support, which will include vitamin E supplementation for deficiency and gluten-free diet if sensitivity is present, and balanced nutrition optimization. In medical management, gamma globulin injection for ataxic telangiectasia, muscle spasm medications, eye move for eye movements, and other controlling drugs. So, after all of this presentation, we have some of the key clinical consideration, in which the first one is integrated approach. A successful ataxia management requires coordinated application of proprioceptive, vestibular, and balance training techniques alongside psychological support and medical intervention. Treatment must address the interconnected nature of sensory system and cerebellar function in producing coordinated management. Next, there should be a patient-centered care, individualized program based on the type of the ataxia, severity of ataxia, and goals of the patient to ensure the optimal outcomes and functional independence. Regular reassessment using standardized scales guides treatment progression and goal adjustment throughout rehabilitation. So thank you all. It was my presentation on ataxia and role of physiotherapy on ataxia. I hope you all liked it, and thank you everyone.